Okay. All right. Thank you all for joining. We're going to go ahead and start the PACES meeting. My name is Dale, your chair. So I'll be starting this, and then we'll run through the agenda as we go. So I think we're near quorum or at quorum. So I would like to call the meeting to order. And then if you would, Shelley or Adam, I'm sorry, please.
We're pitching it to Savannah.
Oh, Savannah does the roll call.
Heather Berner,
Hi, I'm here.
Dale Woolridge,
And you might need to stand by.
Raymond Proa, Jordana Carpenter, here. Tony Carazino, Mickey Kovac, here. Heather Miller,
I think she's online, but she's like finishing up another meeting.
Let's see her. Rachel Munn,
Here.
Darren Webb,
Good afternoon. I'm here.
Ann Stafford, Christopher Gilbert,
Here.
Joshua Ziedler,
Says he's here in the chat.
Damian Johnson,
Here.
Brett Flanagan,
Here.
Danielle Poteet, Allison Welch,
Present.
Lauren Bond,
Present online.
Doug Costal,
Here.
Martin Samaniego,
Here.
Kayla Manjares, Don Bailey, Rex Harmon.
Here.
There is
Okay. Well, welcome to everybody and welcome to all committee members in attendance. I do not think we have any committee members, but we do have always leave an opening here for committee members who want to make an announcement or introduce themselves again if they're new. Okay, hearing none, I will point your attention to our attendance report. That'll be in your agenda. As a list in your agenda, as a reminder, if you miss 2 consecutive meetings, the Bureau will reach to you and confirm your ongoing ability to attend and your interest. So go ahead and take a look at that and see how you're faring. We do have a new vacancy. We just identified this one recently. That's a vacancy as a representative for the American Academy of Pediatrics. That's a defined committee member position, although I understand what the Bureau applications are open. So if you're interested, send your CV to Savannah or Shelley. You can find those emails on our agenda, and we'll be hoping to fill that vacancy soon. I'd also like to point your attention to another item that's in the agenda, and that's our calendar for our scheduled meetings throughout the year of 2026. Please make a note on those and go ahead and put them into your calendars to have those dates and times reserved. That concludes my chairman report, and we are now stepping to the Bureau report.
Thank you, Dr. Ulrich. I will go ahead and give the Bureau report. First, I want to do a big welcome to Chris Hale, who is our new Bureau Chief for the Bureau of EMS Trauma Systems. So we are really excited to have him joining us here today. This is his first week with the Bureau. He has been within ADHS for some time, but new to the Bureau of EMS Trauma System. So we appreciate him being here. We are keeping him busy with lots of meeting requests that he's getting from both internal and external stakeholders. So welcome to the team.
Thank you.
I wanted to make sure we also officially welcome Savannah, who has joined our team and taking over for Aubriana, who was here previously with PACES. So welcome to the team. This is your first PACES meeting. So welcome, Savannah. Also recognizing Donna, who retired recently after 27 years with the Bureau. So quite some time serving the Bureau of EMS Trauma System, both our internal and external stakeholders. She worked extensively with our trauma center. So she will be missed as well. We do have several openings that are under the enforcement and CON section. And then pending education vote, a thank you to the support group. Education did approve the education module on children and youth with special healthcare needs. So really excited to have that go live. A big appreciation of everyone's patience. I know that took a little bit longer than intended, but I think the final product will be a really good resource for the region. Some other Bureau updates. I won't go through all of this. It is in your packet, just to kind of make sure everyone is aware. If you do not currently get the Bureau of EMS Trauma System email announcements, there is a link to do the Gov delivery to sign up for those. You can sign up for as much as the Department of Health Services announcements as you would like. If you want it to be specific to EMS and trauma, just make sure you select that area as well. Naloxone leave behind. We've just been mentioning a big thank you to all of our EMS agencies who are participating in that program. We've seen a significant uptick. We now have 68 agencies across the state. We have a really nice map that shows both an urban and rural distribution across the state of areas that are doing naloxone leave behind. We are up to over 2,500 kits that are scanned. So we are reminding our EMS agencies the QR code on those kits is universal. So if they forget to scan that QR code when they hand the kit out, they can scan any other QR codes. And just thank you that everyone is participating in this program. We do know that the opioid epidemic, unfortunately, in many parts of the country, those numbers have been decreasing. They have not been decreasing in Arizona. Our numbers have actually been going in the opposite direction. So we appreciate the commitment from EMS throughout the state of really addressing the opioid epidemic. So thank you to everyone who participates in that. Some other links are in there as well. For those of you who are interested, we do have our shared dashboard, which is our cardiac arrest dashboard that did go live. So this, as we took over the data piece from University of Arizona, we now have our shared dashboard for 2023, 2024, and then we'll be able to publish 2025 data shortly. So really excited to see that go live. Agencies also started to get agency specific reports last week. So if you know of an EMS agency or you're with an EMS agency, if you want your report and you have not received it, we'll put in the chat how to request that report. One thing we do want to point out, we did have some pre-hospital coordinators who had requested their share report. We aren't able to give you an agency share report because it is specific to an EMS agency. Once an EMS agency has their own report, they can share it with whomever they would like. So we just wanted to point that out. We just can't give an EMS agency's data to someone that may not be a part of their entity. So we wanted to highlight that piece as well. And I think that is the main pieces we covered today for the Bureau. So thank you.
Yeah. Thank you, Dr. Bradley. You know, one comment that I want to make, we had our child fatality review just a couple of days ago in Pima County, and we had 6 overdose deaths. 4 of them were identified dead by family members without an opportunity, obviously, to rescue. 2 of them were on the Tohono Nation, and the field interviews did identify that they had Narcan available, but again, found the individuals after they were already deceased. So, but anecdotally, I think, you know, it would be, we're going to later look at the child fatality report, the annual report. It'd be interesting to see if there's, if you've been able to identify Narcan in regards to those cases.
Yeah, that is very useful to look at. So
Yeah.
thank you.
Okay. Well, that completes our Bureau report. We're now stepping down to next agenda item, discussion and action items. First, to discuss, amend, and approve the draft of the PACES meeting minutes from July 10th. That was our last meeting. May you have a motion to review? Thank you. And seconded. For those of you who have the minutes in front of you or in the agenda packet, give you a moment to review.
I heard Chris. Did you second?
I just had
Okay.
cost.
Thank you, Doug.
Do I hear any amendments or deletions proposed for the meeting minutes for July 10th? Hearing none, I would ask for a motion and a second to approve those meeting minutes.
Motion, no cost.
Okay, thank you, Doug.
Allison Welch, second.
Okay, Allison, thank you very much. Okay. For those of you who approve the meeting minutes, say aye.
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 For those who do not approve, say nay. For those who abstain, say aye. Okay, the meeting minutes are approved. Thank you so much. Next agenda item is to discuss our 24 Child Fatality Review Report. Adam.
Yeah, I think Morgan Anderson. Morgan, I see you on. Are you able to come off mute and talk with us about the child fatality review?
Yes, I am here. Can you hear me all okay?
Yes, we can hear you in the room.
Okay, perfect. So I'm just going to go quickly through some topics that were pointed out as topics of interest from our fatality report. And then if we want to dive further into anything at a future meeting, please let me know. So thank you all for having me. My name is Morgan Anderson. I'm the manager of the Child Fatality Review Program within the Bureau of Assessment and Evaluation at ADHS. I can give you just a little bit of background of our program for those not familiar. So legislation was passed in 1993 authorizing the creation of our program. We provide comprehensive reviews of every child birth to 17 years of age who died in Arizona. And we look at the possible factors surrounding a child's death to identify ways to reduce preventable fatalities. Information collected during those reviews are then put into a national child death review database, and that results in the data set and findings that are published in our annual report. I'll have a link to that and I'll throw it in the chat as well because it's got a lot more information than what I'm going to share today. But looking at just a general overview, so this is our 2024 data. It was just published on November 14th, so this is hot off the presses, but in 2024, we saw 791 total deaths. 32 of those were out-of-state residents. 380 deaths were determined to be preventable, so about 48%. 419 deaths were among children under the age of 1. 113 deaths were found to involve neglect or abuse. And 72% of children who died of neglect or abuse were less than 5 years of age. Substance use was involved in 15% of child fatalities, and the top 5 leading causes of death were prematurity, congenital anomalies, motor vehicle crashes, suffocation, and firearm injuries. And then just looking at the child mortality rate. So the mortality rate has remained relatively stable since 2015. It did decrease by 7.6% between 2023 and 2024. So that was good news to see. From 2015, the male child mortality rate has been generally higher than females, as you can see in that green line. And from 2023 to 2024, both male and female mortality rates did decrease. So then looking at our preventable deaths, we'll skip this one because it's kind of heavy on the data, but looking at our preventable deaths, so again, just a little background, we use the term preventable death throughout our report, and that's looked at by our local teams. And the way they determine that is that either yes, probably the death could have been prevented, no, probably not, or that the team could not determine. And a child's death is considered preventable if the community or an individual could have reasonably done something that would have changed the circumstances of the incident and the fatality. So looking at our preventable deaths, again, like I said, 380 child deaths were determined to be preventable, 368 probably not preventable, and then 43 we were unable to determine. Motor vehicle for preventable causes of death, motor vehicle crashes followed by suffocation, then firearm injuries, drowning, and prematurity. And we can skip that one too. And then looking at, so this is just, I pulled a few different topics for manners and causes of death just to share some of the data. But again, if you're looking through the report and there's another topic of interest, feel free to reach out. Looking at our suicide fatalities. So there were 43 total suicides in 2024. 100% of them were determined to be preventable. The top causes were firearm injuries and strangulation. We see almost half of our suicide fatalities were due to a firearm injury. Did we have a question?
No.
Okay. And then looking at the leading risk factors for suicide. So within those fatalities that we reviewed, there was a recent warning sign of suicide in 79% of the cases, child relationship issues in 74%, school issues, followed by prior suicide attempt. And lastly, there you see the mental health or substance use disorder. And then looking at the mortality rate, again, the suicide rate among children 10 to 17 years decreased by 21.7% between 2022 and 2023. Males have a generally higher rate compared to females, and both decreased between 2023 and 2024. Looking at the breakdown, the age breakdown, or the sex breakdown, sorry, 71% male, 29% female. And then looking at the age breakdown, so the majority of the 15 to 17 year age at 69% and 10 to 14 age, 31%. And then, like I said, really the goal of our program is to identify prevention recommendations to aid in future prevention efforts. So I won't go through all of them, but we have our prevention recommendations for each of, for some of our manners and each of our causes of death. And just for suicide fatalities, the number one recommendation was increasing access to effective mental health care for Arizonans, followed by availability and accessibility of counseling, therapy, crisis behavioral and mental health services, conducting universal screenings of mental health issues during healthcare visits, followed by some increasing resources for schools to implement some suicide mitigation programming, and then the encouraging responsible firearm access and ownership. Next are motor vehicle fatalities. So we saw 82 motor vehicle related deaths. This was 10% of all child deaths. There was no change in the mortality rate between 2023 and 2024. 100% of them were determined to be preventable. 61% were among males. And leading risk factors that were identified include a CPS history with the family, lack of restraint use, reckless driving, inexperienced driver, and excess speed. And more than one of these could have played a role in one fatality. And then one thing I did want to note is that there were disparities identified. Black children made up 16% of motor vehicle crash related deaths, but comprised 5% of the total child population. And Hispanic children made up 52% of motor vehicle related deaths and 47% of the total child population. Next, looking at the age breakdown. So you can see the 44% of the fatalities occurred among 15 to 17 years old. And what I really wanted to point out on this chart as well is when we look at those less than 5 and 5 to 9 age groups, we're at almost a third of children that should be in some sort of restraint when they're in a vehicle. And we did note that as one of the risk factors was lack of restraint use. This next, the location of the decedent at the time of the motor vehicle crash. So in 50% of cases, the decedent was a passenger, and then in 26% the driver. Again, just pointing out 1 in 4 of these cases were a driver, and that really shows a need for education around safe driving. Again, with the risk factors being reckless driving and inexperienced drivers coming up on a lot of these cases. And then again, our recommendations. So fittingly, not the first recommendation was promoting safe, sober, distraction-free defensive driving for young drivers, followed by encouraging families to follow the recommendations for proper restraint, child restraint use. And then next, I'll look at our neglect and abuse related deaths. So for our neglect and abuse related deaths, there were 113 total deaths. Again, 14% of all child deaths, 100% of them were determined to be preventable. 81% involved neglect and 24 involved abuse. Again, there could be neglect and abuse involved in any case. Looking at the top causes of our neglect and abuse related deaths, so suffocation, motor vehicle crashes, blunt force injury, drowning, followed by poisoning. And the leading risk factors included CPS history with family, parental substance use history, poverty, substance use, and lack of supervision. And just to differentiate between the substance use, so parental substance use history is any documented history of substance use concerns by the parents, and then substance use is substance use at the time of the fatality. So that could have been the decedent, a caregiver, a stranger that was under the influence that effectively caused a fatality. Looking at our mortality rate, so overall Arizona's neglect and abuse mortality rate increased from 2015 to 2022. In 2023, however, the rate declined by 21.4%. 2022 and 2020, or 2023 and 2024, sorry. And then looking at the most common manner of death that was classified as a neglect or abuse related fatality. So 54% were those accidental injuries where some form of neglect or abuse was identified, followed by 20% of our homicides and 15% of our natural cases. And then for our neglect and abuse related deaths by age group, again, 47% in that less than 1 year of age range, and then a quarter in our 1 to 4 year olds. Again, I wanted to note a disparity that was found in our data. So American Indian and Black children made up 10 and 15% of neglect and abuse related deaths, but each group comprised 5% of the total child population. And in 2024, Hispanic children experienced the highest percentage of neglect and abuse related deaths at 47%, and Asian children experienced none. Looking at the perpetrator, mom was the perpetrator in 73% of neglect and abuse related deaths, and father was the perpetrator in 36%. Again, mom and dad could have both been perpetrators in a case. And then that's followed by our parents, partner, step-parent, child care provider, foster parent, or grandparents and siblings. And then looking at our prevention recommendations, so increasing availability and accessibility of affordable quality mental health and substance use treatment services was number one. Number two, and this came up in several different areas, but increasing availability of home visiting programs. And then number three, encouraging Arizona policymakers to invest in families' financial well-being, and that includes support for healthcare, food, housing, employment, and childcare. And then lastly, I'm going to share some of our SUID data. So for our sudden unexpected infant deaths, there were 66 total SUID fatalities. There was no change in the mortality rate between 2023 and 2024. 94% of those fatalities were determined to be preventable. The top causes were suffocation and, unfortunately, the undetermined categories. Leading risk factors include an unsafe sleep environment, objects in the sleep environment, poverty, unsafe sleep location, and parental substance use history. And one thing we did want to note was 16 of these SUIDs were linked to the use of a consumer product that was not meant for sleep. And 12 of those cases involved using a U-shaped nursing pillow for sleep. So Arizona's SUID mortality rate has fluctuated between 2015 and 2020. Until 2022, we started to see a decrease, and it's remained relatively stable since then. And the unsafe sleep environment mortality rate decreased by 1.3% between 2023 and 2024. However, the suffocation mortality rate increased 8.3% from 2023 to 2024. And then looking at the age range, again, the majority of these fatalities occur in children 28 days to 1 year of age, and 9% in the birth to 27-day age range. Again, noting a disparity that was identified. So Black children made up 15% of SUIDs, but 5% of the total birth population. Hispanic children had the highest percentage of SUID fatalities at 44%. And then looking at our prevention recommendations. So again, that educating parents on safe sleep environments, increasing home visiting programs. Those are the programs that can offer safe sleep education at every visit. And then again, encouraging investing in families' financial well-being, mental health and substance use treatment services, and parent education on parenting strategies. So that's all the data I have, but with the discussion about substance use, I know Dr. Woolridge brought that up, so I looked that up really quick, and I just wanted to share from our report. So I shared that substance use contributed to 118 child deaths in 2024. The mortality rate did decline between 2023 and 2024 for our children birth to 17. Marijuana was the most commonly used substance, followed by alcohol and then opioids. And then fentanyl was responsible for 11 of those opioid poisonings, and naloxone was known to have been used in less than 6 of those poisonings. So I just wanted to share that with the discussion on naloxone, and there's definitely room for prevention improvement there, and emphasizing the importance of naloxone. So that's all I have for you today. I know it was a lot all at once, so I'm happy to answer questions, or again, if you look through the full report and have other questions or areas you want to learn more about, please feel free to reach out.
So I just have a question, and I think it's a broader question for the entire presentation, really, regarding the recommendations. But what in particular that stuck out to me was the suicide prevention recommendations, and number 3, conducting universal screening for mental health issues. So with these recommendations, is the department putting together any plan of implementation to provide to providers on how to implement your recommendations? And I bring that up because there is a problem with the payers currently and only being able to reimburse for screenings, 1 or 2 screenings. I know we're dealing with it with the maternal health issues, especially the postpartum visits. That's why we created that committee that's supposed to start beginning of the year, to focus on some of those things. But they're only going to get reimbursed for the first visit, but they can't, so that the doctor doesn't have the time or resources to keep doing that. So I'm just curious if that's a part of this process, or if it stops at these recommendations.
So that's a really good question. So for our recommendations, we're hoping, and we work with our community partners to figure out ways to implement them. And we want to help however we can with the data or the resources to help move those forward. This year in our annual report, it's actually the first year we were required by statute to also show our progress towards some of these prevention recommendations. So there is a section in the report, and I can't remember off the top of my head everything that was listed for our suicide prevention recommendations, but it does go into detail a little bit about what the department is doing currently to address some of those prevention recommendations. But if there's gaps still, we definitely want to hear about it, and it's something that we can also include our local coordinators on. So when we're seeing these cases, we can create more specific recommendations to issues like that when we're getting those cases.
So just one follow-up question. Sorry, I'll talk about. With that, you mentioned the policy aspect of it too, with one of the recommendations. I can't remember which one it was, not necessarily under the suicide slide, but policy and legislators to change that information. I think I'm the only registered lobbyist in this room. So is that something, my question, I guess, really is, are you guys able to provide like where exactly policy needs to be changed? Is that something that's within the scope of the department to be able to take back to the legislature, or is that done through Carly or ledge liaison, or how do I help with that is really my question.
That's a good question. So I think, again, that's done through a lot of our partners. I know like the American Academy of Pediatrics, the Arizona chapter, they do a lot of work around that too. So we're definitely here to help make those connections so that that kind of work can be done and that kind of policy change can be done. So if there's anyone else who is working on things like that, we would love to work with them and connect them to make that happen. But we're providing these prevention recommendations to kind of be the catalyst to get the ball rolling, and then kind of help our partners implement some of these prevention recommendations based on what we're seeing in the data.
Perfect. Thank you.
Thank you, Damian, for those questions. Not to have suggest a favoritism, but I am aware because of my board of the Arizona chapter for emergency physicians, and they do an annual day at the legislature. The lobbyist for that state chapter is John Thomas, and they're always okay. Good. Okay. All right. So yeah, always eager to support good, good lobbying efforts.
And we actually share the contract lobbyists with the Academy of Pediatrics.
Great. Perfect.
Also works with us on a lot of things. So okay, there's already those connections. So that's great.
Great. Thank you.
Thank you.
Morgan, thank you so much for bringing up the Narcan related findings. My intent, just to be clear, was by no means criticizing the program. It was more to point out accolades. Each of the cases that we reviewed, and it covered like a 3-month interval, but each of those cases, Narcan was available. The program's working. I think the shortcoming is that the bystanders and family members found them too late and wasn't able to utilize the Narcan. But the getting it out there and having it available, and that was 2 cases that occurred deep within the Tohono O'odham Reservation, which is can be very rural. So the distribution is definitely working.
That's awesome. Yeah, that's great to hear. And that's something we have seen in the recommendations in the past, as far as identifying what we see is they're found too late, because often peers don't know how to identify what an overdose looks like. So that's definitely something when you're doing your reviews too, as a recommendation, that we can be creating more awareness on how to use that Narcan early enough, or naloxone early enough, to actually be able to reverse those effects.
Yeah.
Dr. Woods, we responded to one 45 minutes on flight, and we beat fire there, and the family had given Narcan. And so that was the first time that I had seen the DHS program, the naloxone leave behind program. It was left behind by TO Fire, which is really neat.
Nice.
I talked with Chief Martinez about it, but they dispatched flight and fire. We just were faster because the area operation looked out there. The family had given Narcan, and it was an opioid overdose. So I think that saved that child flight.
Nice.
So I think it is very effective.
Success stories for sure. Yeah. Thank you. Any other questions for Morgan for Child Fatality Review, the annual report? Okay. Morgan, thank you so much. Appreciate it. I'm going to step us to our next agenda item.
Dr. Woolridge,
Yeah.
if I could interrupt.
Please.
One of our speakers, Amy Devins, has contacted me with time constraints.
Yeah.
So if we go out of order and go to item F, so that Amy can present Arizona State Health System.
Absolutely, Amy.
She's on.
Yep, you got the floor, Amy.
Sure. Amy, are you
Hi,
on?
can you guys hear me okay?
Yeah.
Making sure. Okay, I'm joined by my cell phone because for some reason the audio wouldn't work through my computer. So we're just gonna fly by the seat of my pants here for a second. Let me work on sharing my screen.
I can be your backup. Oh,
You can see my background. Can you? Here we go. Can you see that?
yes,
Yes.
Looks good. All right. I'm going to just keep it in the slides rather than the traditional view, just because I'm going to move very quickly through these. You'll have access to the entire slide deck if you're interested. I want to make sure that we leave enough time to go to the crisis dashboard as well. So kind of along the lines, I want to thank Morgan for some of the information that she was sharing. I know that it's of particular interest around suicidality in our youth population. I'll touch on the crisis system in general from the northern and southern aspects of the state. And certainly, I would refer you to Mercy Care for anything in that central region where probably most of you are. But just to be fair, we did go to a statewide crisis line a few years back. Our current structure here, this is our Southern Arizona structure, REBA structure. What I'm going to talk about mostly is that red circle in the bottom left, if you're not familiar. Northern Arizona looks pretty similar. You've got the ACCs in play. We did move into the role as the REBA in Northern Arizona under Care First, and have since started operating under Arizona Complete Health statewide now. October 1st of 22, we did move to that statewide line, 844-534-4673. Last four digits spell hope. You will hear, and I'll just touch on it now, you'll hear a lot about 988. As of February of this year, we no longer have access to any of the crisis data, crisis calls that are coming in on 988. That's not necessarily a bad thing, but from a REBA perspective, we don't have the opportunity to necessarily connect with those members that are calling in to 988 for crisis stabilization. If a mobile team is dispatched, then we're kind of back in play and we do have access. Hello?
We can still hear you.
Okay, good. So which number do you call? I urge everybody, program the number, the statewide number in your phones, have that ready. We have crisis cards available that you can hand out, like business card size. We've got flyers, all of those sorts of things. But if worse comes to worse and you can't remember anything else, 988 will get you routed to a call center. Very likely it will be Solari. It is possible it will route you to another call center somewhere else in the country. They may not be aware of all the different parts and pieces that we have available in Arizona. So just a slight word of caution there. Also, if you have a problem, we'll have to refer you through Solari directly in order to address any problems that you might have. If you're welcome to hit me up, if we figure out it's a 988 call, I don't have insight into that right now. We're trying to work with the feds on that one. But right now that's kind of a no. Just some foundational stuff here. Who's crisis available to? Everybody. Anything outside of a person's ability to cope. We don't have any wrong doors. So crisis line, mobile teams, the stabilization units, those 23-hour OBS around the state, the answer is going to be yes. Now, when we're talking about anybody under the age of 18, there are limitations on which observation units can be utilized because obviously kids can't go to the adult centers. We urge everyone to start earlier rather than later because early detection, early intervention obviously has a significant impact on outcomes, and recognizing that seems to be kind of the theme, recognizing what's happening with a child earlier. There's no wrong call, right? There's plenty of services that are available. Kids can call themselves, parents, family members, teachers, anybody that's interacting. Those third-party callers tend to be pretty high when it comes to our youth population. That's totally fine. The callers are going to want to try, well, the crisis line is going to try or want to try and speak directly to the person experiencing the crisis. We don't measure based on, oh, that's no big deal. There truly is no wrong call. Okay. If it's outside their ability to cope, make the call. We believe in community stabilization and real-time escalation. There's always somebody on call. I'm backing up the system 24/7. We have a whole bunch of folks that are ready to sort of jump in and help to make sure all the pieces and parts work together smoothly. This is an extremely busy slide, but what are we trying to do? Reduce unnecessary detentions, use of hospital EDs, involuntary psychiatric commitments, which doesn't really apply a whole heck of a lot for our youthful population. Revolving door usage of 911, folks that tend to call 911 a lot or have 911 called on them. We're trying to reduce all of that. Again, it goes back to that theme of early intervention is very effective. Again, no wrong door. We have crisis protocols. We're in crisis protocol season right now. Actually, that's what I was working on right before I jumped on this call. We write for all 12 of the counties that we're responsible for. We write crisis protocols annually, and we solicit input and feedback from our system partners to include a lot of our first responder agencies, because these are really intended to be giant cheat sheets. So there's a whole bunch of definitions, because we all love an acronym, right? There's a whole big section on the definitions, but it really kind of lays out the framework of what we're talking about when we talk about crisis systems. We have crisis system meetings. Those are quarterly. If anybody, and they are, again, county specific. If anybody would like to join one, let me know. We're happy to do that. We have crisis materials like I talked about, and then the training and supports. I will pay particular attention to QPR, question, persuade, refer. It's a 90-minute evidence-based curriculum that can be taught through in-person interaction, but it can also be done virtually if that's something that maybe some folks need or are interested in. Auditing, it's great. We have some folks on our team that are instructors, both traveling and doing the virtual instruction. So just, kind of a note there. And I'll also talk about resiliency 5 skills. Again, evidence-based, that's more intense. 4 hours at a minimum, in person, small group work. But really it's about identifying maybe your supports, your natural support. Is it appropriate for our younger pop? Yep, it sure is. It's also really appropriate for teachers, schools, things like that. So if you want to know more, again, hit me up after this. I'm happy to dive into that a little bit more. This is really, Samson Gaines Center put this out many years ago. This is kind of how we're organized and where my team primarily works. So my staff are really trying to intercept, identify and intercept those calls that don't need to hit the emergency services system. So because we understand if you hit 911 and you get a dispatch, a lot of times it's hard to kind of bring that back. We've talked a lot before about alternative destinations and lower levels of where to transport somebody to. We understand once EMS is on scene, it's hard to route anywhere else other than an ED. What we're trying to emphasize is let's go before that, right? Let's recognize, get the community education going, call crisis lines earlier rather than later, but also we have significant partnerships with many PSAPs, the public safety answering points around the state, to try and divert those calls when they hit the 911 call center. Mission and purpose of my team. I'm going to breeze right through that. Here's the who's who in the zoo on my team. If you are working in any of these counties that you want to know more about any of this stuff, these fine folks are out there on the road, shaking hands, meeting folks, and figuring out how we can pitch in and help out. The behavioral health inpatient facilities on this slide, certainly not an exhaustive list. This is a small list. The primary 3 prongs of the crisis system: the crisis line, the mobile teams, and the observation units. The folks you talk to on the phone, the folks that come out to you in person, and the place where you can go. That's really the design. If you really want to dive into crisis system operations and best practices, the roadmap to the ideal crisis system from SAMHSA a few years back. That was Arizona featured in that, frankly. Our system of care, many other states come in to look at how we're all working in concert with each other so effectively. Very quickly, again, I'll just, make note of the 844-534-4673, the providers that we're using throughout the state now. Again, I know some of these providers are working in Central. These are the providers that we're working with in North and South. And yes, they do overlap. And some of them are not just mobile team providers or facility-based services. Some are also health homes. So, does it matter which provider you're getting? No, they're interchangeable. They don't turn into pumpkins at county lines. When we need to do something around critical incident response, we did just have a horrible incident that happened in Page, and we were able to deploy one of our mobile team providers to provide some critical incident support for staff and the kids in the school. And the cool part of this for me is the leadership at that school understood to reach out and ask. That's the biggest thing, right? If you have a plan for emergency management, or you maybe have some gaps, we're happy to help augment any of that, or to fill in gaps. If it's a major critical incident, we're happy to pitch in and help. Our observation units, I'll pay particular attention to CBI opening 2 youth observation units, in one in Flagstaff and one in Kingman. We did have this slated for late 2025. Unfortunately, with some of the grant funds that got raked back from our federal partners and then reinstituted, caused some delay. That's okay. And, if anybody's ever opened a facility, you know what it's like to try and, the construction aspect of a facility is always challenging. But we're slated for 2026. I know that both communities are very much looking forward to having an observation unit dedicated to youth, and maybe some inpatient opportunities there as well. I already touched on 988, so I'm going to skip on by. I'm going to drop into the chat. So it should be the link. Let's see, did the link come through? You guys will have to let me know. If not, I'll work on getting you the actual link. So this is a slice of our crisis data. Couple years ago, we started moving to Power BI in our meetings and doing this through like a PDF sort of format. What we worked on this year was, let's make this available to everybody. Well, you guys get to see my delightful screensaver. So that link takes you to an open source location on our website. Scroll down. If you click the little enlarge button, it makes it bigger for those of us that are wearing glasses and cannot see teeny tiny font. This will initially show you the first 2. I'll draw your attention here. There's six separate screens. The first 2 are going to be Southern Arizona. The second 2 will be Northern Arizona, and then the last 2 are going to be mostly for our first responder partners, and it goes back to Southern and then Northern. So we will have a running tally. We just uploaded all of this. We're working on getting the next batch of data in. So this runs through May of this year, starts at contract year, beginning 2024. You can click into any of these. It reacts. If you're familiar with Power BI, you cannot break this. But this could prompt some conversation. If you want to know what's going on in a specific county, you can pull up a specific county. Again, this is covering Southern Arizona, so all 7 counties in Southern Arizona. You can click into any of these fields. You can hover. It's going to give you the count. So it's pretty handy dandy. One thing you notice, I mean, obviously I've highlighted child, and we are working with our guides here to try and figure this out. Why do we call it child here and up here we're calling it youth? Like, pick one and go with it. You'll notice family member is the primary caller. So this is the primary person that's calling in. So that's a third party caller. Perfectly appropriate. You can call in on behalf of somebody else. We encourage it, as a matter of fact. But this is also pretty interesting. The second highest caller in this category is the kids themselves. So that's great. The more hands or the more folks that we get getting the word out about what's available, man, there's some real opportunity there. These slides, once you click on the field, if I click to the next one and I come back to it, what I've highlighted will remain. So I clicked off of child. If I click off of it, it resets. Again, can't break it. If you're interested in looking at Northern Arizona, you're able to do that. You can click all the way through these. You can look at particular, if you want to go into Navajo County in a particular zip code, you can parse it that way. There's a lot of really neat stuff that's happening. So what we're hoping for, because we used to do this in a manner that was, like I said, screenshot, and then our data analysts would do some discussion in our quarterly meetings. What we're hoping for, since this is sort of out there in the open space, is that you are able to pull this information. It prompts conversation. If you want to dive into a more specific area, we're happy to do that. There's no PHI in this, that's been scrubbed. So again, you can't break it. So it's pretty exciting. And what we're hoping for is that it becomes more meaningful. Certainly some of the data analysts working around the state are pretty jazzed about it. So there you have it. I will jump back to the PowerPoint and I will actually pause for just a second if there's any questions so far, because I am just motoring through these slides. Okay, hearing none. I'll touch on a few additional programs that I think are of particular interest to this group. We do have, because we know, just like 988, the granddaddy of them all, 911, when folks are afraid, when they don't know what to do, they will dial 911. So then it's incumbent upon those folks that are working in a 911 PSAP to be able to triage effectively, quickly, and connect to the right resources. It's a huge area of work. And I tip my hat to those professionals, because over the last probably 10 years, we've been working really hard to integrate more fully. We have crisis staff co-located in Tucson 911, Flagstaff 911, and just recently Bullhead City 911. So we're physically co-locating Solari staff that are hired to work in those spaces, to work directly with those folks, and look for those opportunities to pick calls off the board that maybe aren't of a criminal nature and maybe aren't of a medical nature. So you wouldn't even know that that was happening unless we talked about it, right? It's pretty low key, but extremely effective. One thing that we have found in doing this work is that we thought that we were going to see a significant bump from getting not a bump. We were going to see a reduction from our patrol officers, our firefighter, paramedics in the community, in the field, running to calls. We thought we'd see those numbers go down. We didn't. Those calls are still occurring where they're asking for a mobile team to come out onto scene or making a referral, and that's okay. What we are seeing with these co-locations is earlier detection, which is really exciting. So those folks that maybe would start to churn in the 911 system, they weren't known to us. These were not folks that, in our crisis data we had encountered before. So that tells us a story. So I'm pretty excited about it. If we can impact those types of things, if we can impact getting people on a path to recovery much earlier, great. We are very well intentioned as a community when it comes to calling 911, but the expectation that we put on our public safety answering point staff, it's a big one, right? So let's throw some resources there and try to help out. And by comparison, the crisis system is in its youth when you think about emergency services in general. So it's pretty cool. It's one of the things that I like very much. Crisis trainings, I touched on these. If you're interested in any of them, hit me up. I'm happy to talk about them, what backs any of the curriculum. Additional programs, 911 familiar folks. Again, anybody that's sort of churning in the system is a PSAP, anybody running a 911 call center has a name that keeps popping up or a number that keeps popping up. They can share that over to us. We're happy to connect in with our second responder services and some outreach to try and get appropriate care for that person. Because we know if somebody's calling 911 20 times in a month, very likely it's not a medical emergency. It's probably not, it's just really unlikely that it's anything other than something that behavioral health and crisis would be maybe a more appropriate tool to try and help out. We've got, again, second responders. This is additional programming that attaches in addition to health homes, in addition to outpatient services. You can ask for a second responder to basically walk with somebody. They're peer and family run orgs. Experiencing your first crisis can be extremely frightening and the system can be daunting. So having peers that say recovery is possible, I will, walk with you through this process and help you understand, what this behavioral health language really, what it means and is, can be very effective. So that's all funded, ready to go. We've got 24-hour urgent engagements. This also is part of my team that inpatient facilities, oftentimes somebody experiences a crisis, goes to the highest level of care, and you need to figure out how to connect them to an outpatient provider. Again, sometimes this touches on, maybe they need an SED screening, maybe FMI screening, that's okay. You can tag in just by filling out a form and shipping it over to my team within 24 hours. An outpatient provider will respond. Voice and choice is very important. So we're like, it's an easy way to free up really the inpatient unit staff so they don't have to sit on the phone and call around, look for an outpatient provider who's accepting, and that can be very burdensome. So we take that responsibility. Tips and tricks. If you have any problems, you're going to be asked a few questions on the crisis line. They will want to speak directly to the person experiencing the crisis, if possible. If that's not possible, that's okay too. Give them your name, tell them where you're at, because keep in mind, SLAR is answering for the entire state to include our tribal communities, our rural and frontier areas. So avoid acronyms and try to tell them where you're at. Name, date of birth of person is really important. Address where you need the mobile team to go. But I'll say it doesn't have to be an actual address. It can be the corner of the Circle K at whatever school. That's okay. That's totally okay. I will mention as well, we have youth engagement specialists. Those are some of our outpatient providers and specialty providers that are working directly in the schools. And that's really impactful to help augment what the schools are facing and what their staffs oftentimes. Sometimes they call directly to police, and really what might be more effective is having some crisis intervention and having them on scene. So again, if you want to know more about the YES program, happy to talk more about that too. If you have a problem, you can ask for the supervisor. The crisis line is the pivot point. That's where you call, ask for the supervisor, tell them what went wrong. If it still feels like it's just not going the way that I've described, you can ask for our on-call person. I again am on call all the time, so you might hit me, you might get somebody else on my team. We believe in real-time problem solving, critical incident support. Happy to help with any of that. If it's not an emergency, but you just want to let me know, Date and time of the incident, subject name and date of birth, and brief incident summary very much helps. That's my contact information. I hope I didn't go too long. I was moving real quickly through that. Any questions?
I have a question. Sorry.
Yeah.
Amy, do you guys handle interfacility transportation as well, or is there just initial 911 responses?
Under the crisis umbrella, interfacility transfers not something that the crisis system does. That would be probably a contracted AMBO provider in that area.
Yeah, that's some of the concerns because I've been holding a stakeholder meeting since July with a lot of ambulance folks and the fire union and everybody else trying to handle some of these concerns. And one fire district in particular, 64% of their calls, interfacility specifically, last year alone were behavioral health. And there's some concern as well about if a firefighter or paramedic or EMT or whoever, whether it's private or is the right individuals to be transporting these in crises. So I guess that's something I'm going to reach out to you though, Amy, because I think that I got a lot more questions and I'm not going to bore everybody in the room, but thank you.
Yeah, absolutely. Happy to chat. Hit me up. You've got my contact information. Yeah, we can dive into that. Again, I will just kind of, go to the beginning of all this. That's why I push so hard to try and do things to stabilize earlier rather than later, because we know once escalated and once we get emergency services involved, it becomes really hard to untangle. And frankly, it's a burden on our, BLS transport. I definitely recognize that.
Any other questions in the room for Amy? Amy, thank you so much for a great presentation. We appreciate hearing about and you're seeing your slides about the statewide crisis system. Thank you.
Certainly. Thank you.
Okay, we're going to move back to item number C on the agenda, and that's to discuss pending education committee vote. And this is in regards to our work groups. As Dr. Bradley had mentioned earlier, we had children and youth with special health care needs. That product has been approved this morning in the education committee, and it will go to publication. So congratulations to everybody who worked on that. It was a great product. Great set of work. But in the same vein, our next steps are going to be working on another work group, and that's education voted this morning to assemble a work group on developing training materials for child maltreatment. And we would like to partner with them going forward. This was a previous agenda item, so I don't think it's something we have to approve at this point, other than to take maybe a list of people who want to participate in that work group. And you can email Savannah, email Shelley, or shout out now if you want to participate in that work group. I won't put anybody on the spot. We won't voluntold anybody.
I volunteered during the education committee meeting too, but pretty close to the gal who organized the child maltreatment symposium in the state. So
great.
I think a lot really did starting.
Well, and it doesn't have to be committee members, so have those individuals join us. So yeah, that would be wonderful. So and anybody in the audience who's interested too, again, email Savannah. Okay. All right.
Dr. Ziegler.
Oh, Dr. Ziegler, thank you so much. Ziegler, we'll get you on the list. Appreciate it. And
John Holmes.
You're welcome.
John Holmes, Lauren Bond. Wonderful. Yes, I volunteered in the education committee. Yeah. So, yeah, Jordana's on the list also. Okay, wonderful. So that will be an exciting group. So next agenda item is agenda D, discuss, amend, and approve the uptakes to ADE Red Book. Adam, do you want to, Savannah's going to be doing this one. So another great project that we worked with through the work group process. So I won't say more.
Awesome. I hope everyone can hear me. I'm not the loudest. Okay. So for some background, there was a work group formed after ADE asked for PACES to review their red book. And this is the product of those work groups. So as we move through it, you will see the work group suggestions in suggestion mode on the Google Doc, except for those within specific flowcharts. We looked at 5 different flowcharts, and those ones were a little bit impossible to work with. So I'll show you, but the changes are bolded, italicized, and underlined in a separate flowchart for you to see. So today we're going to walk through those. Please stop me if you have any thoughts, Tyler. So here's one addition to check to see if a student has an individualized plan as a blanket recommendation for any of these conditions. And then you'll also see here some added language. Will it be more helpful if I read through them?
I'm okay viewing them as you scroll. If anyone wants Savannah to go slower through these, just shout out. The screen seems to be cutting them off a little bit on the right, though. There we go. Perfect.
And then here, there were some specific additions that the work group suggested. So we tried to incorporate that into the paragraph that already exists here. And then just wanted to make sure that we included the 2 recommended additions here. So if anyone would like to change what we added, please let me know. And then we had a few just general recommendations for the Red Book document as a whole, which were within the flowcharts that we'll see in a second to standardize the location of the ARS statutes. And then also the references to individual student plans within each flowchart so that they're in the same spot, to hyperlink or reference the CPR flowchart, and then again to ensure that the student's individual plan is checked first. So this is the first flowchart the group looked at for AED use. And The changes here, so this is the original version. And the one with the group's recommendations, including adding a title, changing in the first red box, in the original it said paramedics, so changing that to EMS. And then removing within the no shock advised box, one of the bullets. It's that. We also looked at CPR. The ones in between, we didn't change anything, so apologies for scrolling. So this is the original flow chart in the red book for CPR. And then this one includes what the work group suggested, which simply was to add a link in this box to the AET flow chart. The next one we looked at was diabetes. So here's the original from the red book. And then the one that includes recommendations from the work group. The recommendation here was to add call 911 before administering anything to the student. We also looked at the diarrhea flow chart. So this is the original. And the changes suggested include reassessing every 20 to 30 minutes. And then adding contacting the parent or guardian to pick up the child specifically. Also to provide water. And the last one that the work group looked at was seizures. I'm sorry. So this is the original seizure flow chart in the red book. And the work group's recommendation was to reference the Ohio State's emergency red book guide for formatting. For easy. That's the Ohio. Are there any changes anyone would like to make?
Any comments from anybody online or in the room? Any edits, further editing? Okay, hearing none. Oh, okay. Did we motion to review? We did.
Okay, who is first?
I'm not sure. Motion to review? Okay, Jordana, thank you. And second from Chris. So a little bit of background. This was a product that was created through PACES about maybe like 12 years ago with the Department of Education. And it was interesting learning at the time because the Department of Education is totally distinct from the Department of Health. They may have health personnel on school sites at some of the schools, but are rarely RN and mostly nursing assistant based level training. And administration of medicines in the school district is relegated by the principal, who's non-medical. So they're very reliant and heavily reliant on EMS services for emergencies that occur. So it's really, I think it's a great opportunity to stay involved, and that they reach to us to be able to update this document. And it's a very lengthy document, and I'm hoping most of you got a chance to see to go through it, but it addresses nearly any event that could occur on school grounds, and it's a way of directing and advising them on, how EMS personnel can help and when to help. So I think it was a great opportunity, and it was great work by the work group who contributed to all those edits. So a motion to approve at this point.
We've got that. Let's do the vote.
Okay, let's go ahead and vote. Those who approve as displayed, the edits as displayed, say aye.
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 Okay. Those who oppose say nay. Those who abstain say aye. Okay, the document is approved as is with current edits. Great.
Dr. Ward, you might be worth looking at, since the evolution changes every now and then, to revisit that document every 2 or 3 years, whatever cadence might be necessary.
Yeah, in hindsight, I think we missed an opportunity to touch base with them in that interim. So making it a more regular review.
Sure.
I think it's.
ADE has already been on board with that, and she's already putting it to motion to have the cadence be reviewed regularly, as well as making it a live document. So when changes are done, it's just automatically done to the site. They did do QR codes on magnets. So these magnets are in all the classrooms,
Nice.
as well as the badge buddies and it has like a title, whether you're a nurse, an aide, or just somebody who's a quote unquote health person. And it has a QR code so that even if they're out and about on playgrounds or whatever, they have the access to the red book on their badges.
Nice.
So just a little tidbit.
Very cool. Very cool. Okay, well, hopefully, I hope everybody heard you, Jordana.
Oh,
That-
sorry.
That those are great efforts, great work. So, okay. Next item is item E, discuss the stab report. And that's particularly the PEDS data. If you do have the agenda open, there is a hyperlink apparently in the agenda. Is a bureau going to be doing that, Adam? Is Vatso available?
Thoughts on you on?
She had reviewed it in previous meetings.
I think she was going to be a little more centered on the pediatric information, but it appears that she's not on.
Okay, if she does join us later, we can come back to it. Okay,
Well, we could just, without her, just kind of point to the fact that it exists and then show everyone on the call that you can filter through the trauma report for the pediatric population. So if you're interested in kind of seeing what trauma looked like last year or previous years, but it's up to date through 2024, this is on our website as a resource. So you can kind of click through that.
and maybe touch base with her if she finds that she really would like to communicate this. Maybe we can have her return for our next meeting.
Sure.
Add her
Yeah,
to the
and
agenda.
if anyone has questions, if you're looking at it and you have questions about something, you can feel free to reach out to any bureau staff member and we can help direct you to the answer or get that from Bob.
Okay. All right, our next agenda item is G, and really this is truly a standing item. We do a lot of our work and valuable work through our work groups. We just mentioned our work group for child abuse related disease and treatment. We leave it open to committee and non-committee members to propose future work group ideas. If you have one to propose, we would get it onto a later agenda, review, and vote to approve the formation. But does anyone have any suggestions for future work groups that we could be looking at? Okay, hearing none, I would brainstorm. This is our ongoing work, and then maybe reach out to Savannah if you guys have any ideas. All right. Next agenda is to step to updates and resources. for option, for item A, pre-hospital pediatric readiness project assessment results for Arizona. We have a hyperlink in the agenda for that.
That is also me.
Ah.
So, the Arizona Pre-Hospital Pediatric Readiness Project, the PPRP, is the survey for, pre-hospital pediatric readiness. And the results, came out. So I am gonna share those very briefly, with you all. And we are focusing on the ALS results because the number of BLS agencies that responded to the survey is not enough to be representative of the state as a whole. So that's why the focus is on ALS. We had 54 ALS agencies respond to the PPRP. And this is our average score of 69, which is it's a range from 0 to 100. These are oops. Sorry. These are just the different domains of the survey. So thank you. So for example, of the agencies that responded, in terms of pediatric equipment and supplies, there was a 92% on that one. And then of the agencies that responded, 37% had a PEC for pediatric emergency care coordinator. And what's really interesting, I'm gonna briefly skip over that first time, is that the average score, the median score of an ALS agency that had a PEC was significantly higher than an ALS agency without a PEC. These are just of agencies that had pediatric skill checking. 78% were demonstration at a skill station, 67% were in a simulated event, and then 35% were observation during an actual patient encounter. And 83% of the ALS agencies that responded to the PPRP had pediatric considerations in their disaster plans. And this is the breakdown of that. So for example, 67% of them had use of the pediatric disaster triage tool in their disaster plan. And that is all for that. Is there any questions?
I think the next two items are also you, but just to keep an idea or keep an eye on your clock here. We're
Yes.
running a little bit late on short on time.
Very briefly, we just talked about the PPRP, which is for pre-hospital. Next year in early March, the hospital survey comes out, which is the National Pediatric Readiness Project, NPRP. So that survey that assesses emergency department pediatric readiness will be coming out in March. And then we also wanted to provide an update about our MARC program, the Making Arizona Ready for Kids, which is our pre-hospital recognition for EMS. Yeah, for EMS, for pediatrics. The application period used to be at one time during the year in the winter period. Now it is ongoing. So any EMS agency can apply at any time for that recognition. And that's all.
Okay. Savannah, thank you so much. A question, I'm not seeing it. Would you mind? Shelley reads it out loud.
Also, Lucas, I think this really speaks to the importance of having an identified PEC. What is being done under PACES to encourage more PECs statewide?
I think we're going to find a little bit more about that out with the return of the NPRP, and as we look at the PPRP a little bit closer, it's well known that PECs have that kind of have a positive effect on pediatric readiness in both hospital and pre-hospital settings. But Allison, that's definitely something we can focus on as a topic of interest for developing a PEC workforce, which we have visited in the past, but we can. I don't want to say revisit it like we haven't been doing it, but we can put more force behind it with additional volunteers.
That is a goal for part of our ongoing with like the art program and with the ACAEP with their P-TECH sites.
Yes.
So we are trying to do more PEC training and getting that in situated to figure out how we can do that better. So if you have ideas, please bring them forward.
Yeah. Yeah, both of the Arizona chapter of the American Academy of Pediatrics houses the pre-hospital designation system, and the PEC positions required for membership and designation in that system, but also our hospital-based systems, the MARC program. Is our, yeah, but in both regards, and I'm sorry, I said those backwards, didn't I? Yeah. But both of those regards, PACES was integral for the creation of the emergency-based system. Similarly with the pre-hospital system, and we have members who participate in those site reviews. So I think we cross-pollinate and support pretty well, and the communication is pretty heavy. With Ann Stafford being one of our committee members from the Arizona Academy of Pediatrics, has always had really good input to PACES. So, but I think those efforts, Allison, is because we do recognize the value. Absolutely. But you're right, we need more infiltration throughout the state. Okay, I know we're running out of time. Agenda items for future meetings. We will be creating a work group to review our bylaws. That's a 3-year cycle. So expect that in the coming year, 2026. Again, look at your schedule of meeting dates in 26. We are always looking for future agenda items. So please email Savannah with agenda items, including potential work groups, because that has been a very solid product that PACES has done in the past. Next gen item is a call to the public. Anyone with an announcement or event, please.
To that last comment about supporting PACS development, you can support that with Western Illinois. We do work in the Western, also nationally with the other PCOEs to develop training for PDS, webinars and that alike to provide ongoing encouragement and education for PACS.
As well. That's a part of that as well. So yeah, we're looking at that too.
Great. Okay, call to the public. Any other announcements? You have a whole list of future events that extend into and beyond the new year. So take a look at those. Those are listed out. I will not bore you with reading those to you. And that is the last item on our agenda. Hearing no further announcement, our next meeting will be March 19th. Same time, same place, but also virtual through the electronic meeting system. And meeting is adjourned. Thank you.
Thank you, everybody.
Thank you all.